So the question is, which kind of patients in nephrology would better need a genome sequencing approach? So if you read my, saw my presentation, I decided to give you a very basic concept to start to understand what does mean sequencing DNA of a patient. For a lot of years, we talked about genetics, but then since about 10, 15 years, we also kindly changed this approach from genetic to genomics. And what does it mean? That before we mostly thought about one gene at a time, but now we know that the genomic background of each patient is very important to understand the phenotypic aspect and the clinical pattern of the patient that we usually meet in clinic. So which kind of patient would need a genome sequencing approach? An important difference is targeted resequencing and genome sequencing. For genome sequencing, we mean analysis that includes both coding and non-coding sequence of our genomic background. So we usually reserve this kind of approach to patients that, for example, patients with a very difficult molecular diagnostic panel, or patients that can be compared with other patients. For example, I worked on very large cohorts of patients with the same disease. For example, 350 patients with nephrotic syndrome that we needed to compare with a very large amount of controls. Because remember that every time we are looking for something new, if we want, for example, to understand if there is a new gene in a specific pattern for a specific phenotype, whatever, nephrotic syndrome, hypertension, glomerular disease, tubulointerstitial disease, also malformation, ADPKD, or whatever, we need to look at a very large amount of patients, because to highlight a single mutation in a single patient mostly will never allow us to recognize a new aspect of the disease. So we need always to compare cases versus control, and the controls are usually should be 10 times bigger than the control, than the cases. So in the genomic sequencing required a very specific understanding of the bioinformatic tools that we usually need to clear all the DNA information that mostly will be not informative. And we reserve genome sequencing to very complex patients. For example, we have now in our clinic a girl, very young girl, with a very heterogeneous phenotype. She has pain, she has vascular malformation, she also has proteinuria, she has some cardiac involvement. So we are going to look both coding and non-coding region of the DNA of this girl. It's an explorative study, because we don't have now in this specific case controls with which I can compare her data, but is mostly a very tough and large analysis. For targeted resequencing, instead, we mean a kind of analysis in which we mostly have a differential diagnosis in our mind. For example, if I have a patient with nephrotic syndrome that started, for example, that performed kidney biopsy, and then the diagnostic was focused on methylglomerulosclerosis, and we, for example, started a steroids pharmacologic approach, and the patient is a steroid resistant nephrotic syndrome patient, then we need to look at least at all the gene for nephrotic syndrome that we know so far. So far, 2021, we have almost 55, 58 genes that have been recognized as genes that, when are mutated, can be linked with the phenotype nephrotic syndrome, that can be mostly podocytopathy, so minimal change disease, or FSGS. We can create specific panel with next generation sequencing that is a targeted resequencing approach. I hope this kind of basic concepts are clear. Targeted resequencing, we look at the specific gene that we already know, that we already want to explore. Genome sequencing means we are going into the DNA of the patient, and we are looking at gene, so coding part of the DNA, but also non-coding part, and also regulatory area of the DNA. So genome sequencing usually is used to perform the analysis as case control collapsing analysis that I mentioned in my presentation. Again, cases versus controls. Or so far, mostly in our clinic, we reserve this kind of very large data set of analysis to very specific and singular cases, until we will have, and I hope will be soon available, an amount of controls, means patient with no disease or with a complete different kind of background that cannot be in overlap with the kidney disease we are going to look at. So I hope I clarify your question. Please, guys, if you have any kind of question, there are no stupid questions to do. So please be very friendly and go ahead with our question if you have some.